Dr. Linda, I think you can go ahead.
All right, thank you. Good morning, everyone. My name is Dr. Linda Ume, consultant ophthalmologist for Obafemi Awolowo University Teaching Hospital, and I'll be your moderator for today's presentation. I welcome us all to today's third quarterly webinar on glaucoma drainage device to be presented by our erudite speaker, Dr. Godswill Nathaniel. He's a consultant ophthalmic surgeon as well as a glaucoma specialist from University of Port Harcourt, Teaching Hospital, Port Harcourt. So if you have questions, comments, contributions, please note them down so that following the course of this presentation, we can ask our questions or comments later or afterwards. Thank you.
Hello.
Hello, sir. It's good to have you
on,
sir.
Have you made me so that I can share my slide?
We can see your slides on the screen, sir.
Okay, you can see my slide already, eh?
So kindly take it to the introductory aspect. We are seeing slide 61.
Okay. Sorry. Okay. Good morning, senior colleagues and colleagues. This morning, just as the moderator had earlier said, we are looking at glaucoma drainage devices. Well, before I start, I want to say that I do not have any financial interest in any of the products I'm going to discuss in this presentation. I would like to tackle this presentation using this following outline. I'll do an introduction, perhaps give a brief history of glaucoma drainage device surgery, talk about the types of the devices, look at indications and contraindications, the preoperative consideration, go into the surgical techniques, postoperative care, postoperative complications, looking at the various, comparing the outcomes, of the various devices. And of course, we look at how does GDD surgery actually fare with fare compared to trabeculectomy. Then we'll conclude. We know that glaucoma is a challenging condition to manage because the condition that there is no cause, and so it's difficult to have a definitive treatment for such condition, generally in medicine, just like hypertension, diabetes. So that is the same thing with glaucoma. However, we know that reduction of intraocular pressure still remain the only treatment option that have been found to be very useful in reducing or stagnating progression of the disease. We have medicine, medications, lasers, and surgery. And usually when it comes to surgery, in recent times, we've been actually exposed to so many surgical options. When you look at the spectrum of the disease, either mild, moderate, or severe. Where the challenge actually comes in is when you have an advanced disease, a patient is losing vision, and you are actually looking for options to be able to reduce the pressure to a level where you consider to be safe for the optic nerve function. At that point in time, we now begin to look at options. And before now, at least trabeculectomy has been tested for over 5 decades, and up till now is still considered as the gold standard when it comes to surgical management of glaucoma. However, we know that the Achilles heels of trabeculectomy related with complications that can be sight-threatening. And so we look at other options that may be better or in terms of the complication profile. So we now, over the years, ophthalmologists and scientists have been looking for other surgical options, and the issue of glaucoma drainage device actually came in. So what is a glaucoma drainage device? Actually is a device used to create an alternate aqueous pathway from the anterior chamber to the subconjunctival or suprachoroidal space, to channel the aqueous. It has various names. It can be called Sinton, aqueous drainage devices, implants, shunts, as the case may be. Before now, GDD has been actually reserved for refractory glaucoma. And I know that even a lot of surgeons, even these days also, still find it a bit not really ready to actually use it as a first surgical option. However, with 2 landmark randomized control trials that compared trabeculectomy with tube, we now have abundance evidence to say that the use of tube is safe, either as a secondary surgical option or even as a primary surgical option. The tube versus trabeculectomy study actually showed, which we are going to actually discuss later in this presentation, and even the primary tube versus trabeculectomy studies. These 2 landmark studies have actually given enough evidence that these devices are safe. They are very efficacious in reducing intraocular pressure. Looking at this this image, that's a globe. When we go into the surgical options, we look at where the implant is started. You can see that on this particular, this is the plate of the tube, and this is the tube itself. Usually when it comes to the device, because we also have other devices that could be considered as shunt, but they don't have a reservoir. But this one has a plate. Those devices that are strictly considered as glaucoma drainage devices under this category are those ones that has a tube is connected to a plate. If you look at maybe Zen gel, is actually express shunt. It's actually like a shunt, but expression does not have a plate. So they are usually not really considered as glaucoma drainage devices. So they also have their own classification, like the minimal invasive glaucoma procedures. We have those subconjunctival devices that actually channel fluid from the anterior chamber into the subconjunctival space, but they don't have a plate, so they're not really considered as glaucoma drainage devices. In the literature, as we may see, the postoperative success rates have been seen to actually range between 22 to 100%, depending on the glaucoma form and the implant that is used. And so far, it's been noted that the failure rate is low. It's low. So let's look at the history of GDD surgery. The very first attempt at using GDD surgery was done by Rollet and Moreau sometime in 1906. This was used to treat absolute glaucoma, and the patient was obviously blind. And I think they used something like a horse air, and it was actually done through the cornea, The very first translimbal implant was done in 1912 using a silk thread, as a centon. Centon is just like something that's creating because the silk thread doesn't really have an opening as part, a lumen. But once you put it through, there's a bit of space. So that space is. Can you hear me?
Yes, sir. Go ahead, please. Thank you, sir.
Thank you. So you have it creates that opening through that thread like this thing actually helps in aqueous drainage. There are many other attempts in the early 20th century, but however, the present day GDD that we have actually began in 1969 by Melton, who actually described the use of silicon tube attached to a polyethylene plate and acted as a reservoir. And he actually did surgery. But however, I think the implant actually failed within 3 to 6 months. Actually has to do with probably the configuration, the design as at that time. So from then, there has been interest, modification, improvement, and by 1976, the first, what could be considered the first melatonin implant was introduced, consisted of long silicon tube. That's what you can consider as commercially available implant. Was available as of 1976. Consists of silicon tube attached to a large template and he implanted it at between 9 to 10 millimeter posterior to the limbus. Around that same time also, I think an ophthalmologist, Krupin and associate also developed the first valve implant. For now, I don't know whether it's still commercially available. I have not seen one. Anyways, by 1992, the valve, non-valve, came into existence with various surface areas. And I think by 1993, the Ahmed valve was also introduced. And over the years, we have now had additional valve, like we shall see when we look at the various devices. We now have more, and we believe that more will come, perhaps with modification, with the design that will help to reduce the complication, especially the tissue reaction that really form the fibrous capsule around it. We'll look at it as we progress in this presentation. So let's look at the drainage implants. How do we classify them? We can classify them using different methods. You can classify them based on the nature, what we call the type of plate, whether it's rigid or flexible. Like if you look at Ahmed valve FP7 is actually a rigid plate. But if you look at ClearPath, Ahmed ClearPath non-valve is actually flexible. Now, when you look at the materials, there are various materials that can be used: silicone, polypropylene, hydroxyapatite, and others. Sometimes these materials are actually combined. You may have the tube as maybe silicone, the plate as polypropylene, and vice versa, or the entire implant is just made of a particular adhesive. We may see as we progress that silicone-based implant appears to be more effective, has been seen in various studies, compared to polypropylene. These are the major two materials that are used now, silicone and polypropylene. Polypropylene has been shown to have a lot of tissue reactions, and so compare with silicone. It can also be classified based on the opening, whether it has a restrictive mechanism, and in that case, it's called a valve. If you don't have a restrictive mechanism, it's said to be non-valve. So those are the major this thing. And this particular classification is what actually inform, maybe when we look at the choice of tube to use, it's actually based on whether you are going to use valve or non-valve. And there are clinical scenarios that will help you determine whether to use valve or non-valve. If you look at this table, I think this gives us a kind of comprehensive types of the various implants available in the market right now. Mortino, that's which is a number. I think it's a number, yeah. It's for silicone. We have the various types and what they do and their reaction, the sizes. So we have clear parts. I think that's the first thing we have there. Clear parts, Mortino implant, Bevel, Ahmed valve, Ahmed clear parts, Paul implant. I think more recently the iWatch implant, which is a bit technologically advanced in terms of adjusting the flow. You can actually adjust the flow by yourself. And each of these implants have various sizes. And as we progress, we find out the benefit of those sizes. We found out that, you know, the larger the surface area, the effective that implant is. However, it's been found that after a particular level, there's actually no difference in the surface, the surface area contributing to the effectiveness of the implant. Ahmed valve, there are various types of implant. I have been using FP7. That's one that is available to me. Ahmed valve. I've been using Ahmed valve and sometimes clear parts. That's one I'm available. Also, when we use at a point Bevel, and recently I've used that, but the one that I use most often is the Ahmed valve. So the various type, you can see the picture giving us various type. If you look at this, is the Ahmed valve FP7. Then this is Bevel. This Bevel is actually designed for a pass planner insertion. This is the Paul. Paul is a recent, I think probably is in Singapore. I've not seen it. So these are various types. And I think one of the challenges we are having in terms of using glaucoma implants has to do with having access to those devices. Beyond the fact that they are expensive, but even the manufacturers are not even making them available to us in Africa, I'm not sure. For Ahmed valve or Ahmed's product generally, if you are not certified by New World Medical, you cannot have access to the product. That's a major drawback aside that. So for those who are certified, we have access to this product maybe at a subsidized rate, not what other people get at the internationally competitive price. This Bevel various sizes. Now let's enter into the meat of the matter. So what are indications? What conditions are you going to use Ahmed valve? Like I mentioned earlier, the GDD devices actually reserved for refractive glaucoma. A patient will have had previous trabeculectomy failed, and you are not able to control the pressure and all that. So those indications still remains, and you will see that they're actually effective. But recently, I tried to search literature, looking at recent systematic reviews and meta-analysis And there are certain things that are beginning to, change, not the way we think. We see that when we look at comparing trabeculectomy and GDD. So we have conditions like neovascular glaucoma, usually effective, but when you are using neovascular glaucoma, if you are suspecting, and you might ensure that you actually address the primary problem, maybe giving anti-VEGF, laser as case may be, you use any implant to reduce your the pressure. We will see whether you're going to use a valve, a non-valve. We see that penetrating keratoplastic glaucoma, retinal detachment glaucoma, iridocorneal endothelial syndrome, traumatic glaucoma, uveitic glaucoma. We had open angle glaucoma, the classical, our almighty primary open glaucoma that's actually had failed trabeculectomy. And GDD has been found to be very, very useful in infantile glaucoma or juvenile, or say whatever, congenital glaucoma. Very useful. If you look at the table before now, we're looking at the various types of GDD products. Some of these manufacturers actually have a pediatric size implant. I've not had access to that, but I've inserted a few of the using FP7 for a congenital glaucoma, or maybe say juvenile onset glaucoma. I've used that and it's quite successful. These are other conditions as to globals, as the case may be. Now, when you look at contraindications, the contraindications where you may ask, do you have relative or absolute? If you actually have a ciliary block glaucoma, you have to avoid the tube. Remember that you are going to insert the tube into either the AC, generally it's into the anterior chamber. And you wouldn't want anything that's going to occlude that. Now, if you have conditions that result in scleral thinning, especially for patients with maybe pathological myopia, they tend to have thin sclera. But I think one of my first implant I did post-training was in a woman who had maybe an advanced glaucoma. Will I say end stage, because it was very, very poor, less than about 160 with poor orientation. And she had a pathological myopia of about -18. So the sclera was slightly thin. So in that case, you have to be very careful when you are trying to secure the plates to the sclera. If you have extensive conjunctival fibrosis, it may be difficult for you to have conjunctiva because you have to cover the plates. So in that case, you can't do that. Relative contraindications, vitreous in AC, which in any case, if you have access to vitrectomy, it can be cleared. And intraocular silicone oil, those are relative. You can actually take care of that. We have facility to do a vitrectomy. Can invite the vitreoretinal surgeon to help you clear that, and you can still put your tube. Active fibrosis, you have to address that by giving anti-VEGF, as the case may be. Now, how does this implant work? We know in the case of trabeculectomy, when you create that you create that what I call it, fistula. There's nothing regular, there's nothing. The tube, the fluid just flows through the ostium and is collected under the subconjunctival space, then diffuse into the surrounding capillaries. So how does GDD actually work? Now, why, you ask yourself, why the plate? The plate itself does not really collect the fluid. The fluid does not collect the fluid. Not like a reservoir. It's not a reservoir. You say, okay, collect the fluid. Now, if you look at what it does is that when you implant and secure the plate, obviously there are going to be tissue reactions. within 4 to 6 weeks. So there will be a fibrous capsule that will form around that plate. When you form around that plate, so when aqueous exit from the anterior chamber, flows into that space around the plate. And from there, it actually diffuses passively into the surrounding capillary and lymphatics. That is basically the physiology of how the plate. Now, you may, as we progress, discover that I did mention that some of the plates actually ignites a lot of inflammatory reactions. So the capsule that form tends to be thick and everything. And as the condition, as time progresses after the surgery, discover that one of the challenges that you have, initially, when you have a thick fibrous plate, the pressure will start rising, especially for the non-valve, because the fluid can actually move in either direction, either from the aqueous, from the AC to the subclavicular space. But if the pressure surrounding the plate is so high, the fluid will start to rebound back, and for that, you see pressure actually going up. However, usually in wound healing, generally, you see modification, remodeling of this fibrous plate, and over time, it becomes a bit soft to a way that it will allow for adequate flow of fluid around it. When we will see it as we progress, that when you use the valve, you see that we have what we call the hypertensive phase and the non-hypertensive phase. So all these things, actually, the role is played by the nature of the capsule that actually forms around that plate. Let's look at the preoperative consideration. Like with any other surgery, one of the most important things has to do with patient selection. A few days ago, the Glaucoma Society actually had the session on trabeculectomy, and one of the first things we talk about patient selection is very, very key. You don't just carry any patient and say, I'm going to put an implant. You must properly select that patient, to know what type of glaucoma. There are some glaucoma that's like a patient that has an angle closure, coronal angle closure glaucoma, for example, and you are not ready to remove the lens. You don't want to put a tube, because the tube is going to touch the dentillum, and you're going to have more problem in your hand than even the primary problem you're trying to solve. So you may have corneal decompensation and everything. Even in the open angle, where the AC is relatively adequate, you have to consider the state, the depth of the AC. If you know that the AC is not adequate, so which means that you don't put a tube in the anterior chamber. It becomes easy for you if you are going to do a combined procedure. You remove the cataract, you can put the tube in the sulcus, and that's fine. It's okay. I think I've done like once or so, right? Putting the tube in the sulcus is also very easy to be done, so that because you don't want to damage the. So you have to properly select the patient. You have to properly work up the patient for surgery. Look at things that will aid complication and try to address them. Infection, you have to ensure that you address infection. If you have eubiosis, you have to ensure that you address the primary cause of eubiosis in case of neovascular glaucoma, and ensure that and before you go in, or you can even do that concomitantly at the time of surgery. You can just give your anti-VEGF, and you'll see that the patients do well. So a proper ocular examination is very important, which visual acuity, want to be ensured that, well, why are you doing this? You want to maintain the patient's visual field, ensure that, well, obviously for refractive glaucoma, and maybe the VA may be a bit poor, the visual field is already compromised. At times when we talk about trabeculectomy for those advanced with split fixation, we say, oh, the risk of wipeout. It's not really like that in implant surgery. We are not really worried because the depression of aqueous is not as sudden as you have in maybe in trabeculectomy. And so you are not really worried, but it could still happen that you have a wipeout, but it's very rare compared to trabeculectomy. What are the, you look at the type of implant you want to use. What type of implant you want to use? What are the things that will consider that will make you to take a particular tube or not? Now, this one, if you want an urgent drop in the IOP, you are worried about the status of the optic nerve head, and you want to drop it, I think the valve is the best option to do because it will drop. Now, but if you know that you have the latitude to wait for another 4 to 6 weeks when the plate will form, when the fiber will form around the plate, then you can use a non-valve. So those are the major ways, the two things you have to consider. You are worried the patient has been on multiple medications, perhaps has even done trabeculectomy, it has failed, but the pressure is unremitting, and you want to drop that pressure. The best option at that point in time would be a valve, because the valve has a restrictive valve, so it can drop the pressure. Most likely, the opening valve for ablative valve is about 8 millimeters of mercury. So you are not, the issue of hypotony is not really a problem, even though in some cases it can occur. So you do that. Those are the two ways you need to consider when this thing. Other thing you want to consider is the patient. Can he keep up good follow-up? Can he keep to the good follow-up procedure? For the valve, the follow-up is not really very, very strict compared to the non-valve, because non-valve, you are actually watching until when the ligation of the tube will actually give way. There's going to be a sudden drop in the intraocular pressure. So you need to monitor this patient closely somehow. But that may not be the case in case of valve. So if you see a patient that is not going to keep up to follow-up protocols, you better use the valve and not a non-valve. So that's another thing you also need to consider. You have to also consider, look at the patient, as the patient clinical medicine, does the patient react? Most patients have some patients who have been on medication for a long time, see their eyes are very red, and the conjunctiva is very, very injected and all stuff. So you want to look at the material. This valve you're going to use, does it contain, is it silicone or is it polypropylene? Like Montino is polypropylene. So if you have access to Montino valve, Montino implant, you avoid Montino in such patients. So you go for silicone. So any valve that has silicone, you can choose that one, because that may not really evoke a lot of inflammatory reaction that will actually lead to thick fibrous capsule later. So those are the few ways to how you select your patients for implants. I've obviously said that even where I want to put the implant, you look at the conjunctiva very well, and say, okay, you may have a conjunctiva in a particular quadrant that is a bit fibrous, but you have good conjunctiva. So you select, you want to select in a small size surface area, which that unnecessary manipulation will not actually be a problem for you. But if you have a very good conjunctiva and the sclera is okay, and you need perhaps a large drop later, and you can afford to wait for a while, you can use a large surface, either 250 or 350. But remember, as we may see, that when you are using larger size plates, you are going to do a lot of manipulation involving the extraocular muscles. And when you're doing that, you have to be mindful of oculocardiac reflex. So you have to look at the patient clinical status. If the patient has cardiac issue, it's better to have the patient surgery done under anesthesia, general anesthesia, rather doing it under local anesthesia, because you don't want anything to have cardiac arrest on the table for you. So the workup of that patient, every patient is present. And most of the times we are dealing with elderly people. So we must ensure that their cardiovascular status is okay. If it's not okay, we ensure that physician consultation is done. And our physician must give us a guarantee that this patient can perhaps be able to lie and tolerate local anesthesia. Otherwise, you just do a general anesthesia. It saves you a lot of problems because you're going to do a lot of manipulation on the muscle for large surface area implant. So in order not to get local reflex, this thing, you better do general anesthesia. But generally, local anesthesia is okay. Subtenon is what I normally use. I use subtenon anesthesia. Some may do peribulbar. But remember that if you are doing peribulbar, you are going to use a large quantity of anesthetic agent. And if the optic nerve is already compromised, you want to reduce pressure on that nerve. So I do subtenon anesthesia between 2 to 3 meals is actually okay for me. If you have and you avoid what you call adrenaline, you can use bupivacaine to give it a longer duration of because implant surgery takes a bit time compared to trabeculectomy. So you have to do that to have adequate anesthesia, anesthesia, for the patient, so that the patient will be able to cooperate very well. For general anesthesia, there's no issue. The anesthetist will be in charge for you to do that. Those are the few things about the post-operative. What are the instruments? Well, I just did this just for sake. Doing a trabeculectomy, the instrument we use for trabeculectomy essentially will be okay for a few things like a pair of muzzle hook may be necessary. In fact, it's not that it's not maybe, it's absolutely necessary because you must identify the muzzle. Even the small plates, the small size plate you want to insert, ensure that you identify a muzzle so that you don't place the plate on the muzzle before you begin to have a restrictive condition post-op, as we may see in the complication. So you have to identify the muzzles and ensure that you are not putting your plate on any muzzle. Now let's look at the surgical steps in implants. I will just take a little of time to outline this. You can watch YouTube and everything, but my own experience as how I do my implant surgery. Obviously, after you are cleaning and over this thing, you have to use a superior corneal traction. You put your corneal infrastructure, ensure that you expose the quadrant you want to actually insert. Yeah, you can put a tube in any of the quadrants, any of them. In fact, there are some patients that have up to 2 or 3 tubes in the eyes, just to ensure that the pressure is adequate. So you have to, as part of your pre-op thing, you have to look at the patient, decide which quadrant you want to use. In any case, if you have a large or a double plate, implant with double plates, so you are obviously going to use 2 quadrants. But if you are using a single plate, maybe like 250 millimeters distance, you can use 1 quadrant, and most likely you just lift the muscles, deciding on which one. If you are using supratemporal, I use mostly supratemporal quadrants. So I will ensure that the superior rectus and the lateral rectus, identify them. So I put the tube between those these 2 muscles. Now, if you are using a large distance, you are obviously going to lift the muscles, and so part of the plate will be under the muscles on both sides. So that's what you do. So you expose your distance and you do your conjunctival peritomy. Now, you can do either a Fornis base or a limber base. Now, let me say this. if you have there are some patients who have small eyes, small eyes, and you want to put a tube, it can be challenging. It can be very, very challenging. So in that case, it's better to do a limber base. So you start maybe around between 5 millimeter away from the limbus. You make your conjunctiva dissection. So you can have a large, you can be able to have a good exposure where you put your plate. Or you do your, but if the eyeball is fairly large enough, you can do your fornix-based peritomy, or you have to do a wide peritomy, unlike when you are doing trabeculectomy. For a beginner, there's nothing wrong. But as you progress, you discover that your size of peritomy will be reducing. But for a beginner, nothing is going to cause any problem. Just enlarge your peritomy enough just to have a good space where you can implant, you can secure the plate. So there's no problem. Now, the conjunctiva is not as so precious, let me use the word, as when you are doing a trabeculectomy. In trabeculectomy, you are very, very meticulous with the conjunctiva. You want to, like, you pamper the conjunctiva in trabeculectomy. You don't necessarily pamper the conjunctiva when you are doing implant surgery, because it's not going to really affect. As long as you'll be able to have a good closure at the end of the day, there's no problem. So that's basically what it is for the peritomy. So after that, now after you have done, now depending on the tube you are inserting, I want to say this, that for a beginner, it's better to start with a valve implant and a small size plant. It's very, very, that's good for you. You use that to actually, don't go and starting where you're going to be manipulating muscles. It can be quite challenging. So it has a longer learning curve. But for a valve with a small size, you can easily do that. Now, if for a valve, once you have done your peritomy, secure good hemostasis, now what you want to do, you want to put the implant, the plate, secure it, and the end of the plate to the limbus, maybe between 9 to 10, or some say 8 to 10, or 8 to 12, depending on this thing. But averagely, what I do is around 9 millimeter from the limbus. That's where I secured my plates. So I do that. Now, if you are using a non-valve, you must prime that. You must prime the tube to ensure that the valve mechanism is working. But I want to sound a word of caution here. When you are using maybe a 27G or 30G cannula to inject the fluid, you have to be very gentle, because if you actually force the fluid through this thing, you could damage that mechanism, and that's the end of that thing. For a new beginner, you may not know. You may just insert it, and you'll be thinking that you have inserted a valve implant, not knowing that you have already destroyed it. So you have turned to what? A non-valve. So you have to be gentle when you do that. So you secure the plate. You can use 9-0 nylon or 8-0 nylon or Prolene. Just secure it. Each of these plates, they have an opening where you actually pass your suture through and secure it on both sides, ensure that everything is okay. Then for the larger implants, that way you do a bit of manipulation, ensure that you identify the muscle, put the plate, the tip, the edges of the plates, the lateral edges of the plates under the muzzle on both sides, depending on the side. But if you are using ClearPad 250, you don't need those things. Once you just put it, the space between the lateral and the superior rectus is enough to accommodate the ClearPad without you putting it under the muzzle. Then for the implant that have two plates, there are some people like Montino, I think they have two, even Ahmed, I think have some implant that are two plates. So you can put one plate in one quadrant, put the other one. There's a connecting tube. So the connecting tube, some say you can put it on the muzzle, some say under the muzzles. So you just do that. Put this one secure on this other quadrant. Maybe you put one on the superior temporal, put one on the superior nasal. That's where you have the plate. Then the connecting tube will just run between them and you secure them. And so that's will be okay. Like I said, I use mostly supratemporal because there are a lot of space there and easy to expose this thing. But maybe if the patient already have an implant there and you want to put a second implant, you may attempt maybe supranasal or you go inferior nasal and put your, or supratemporal rather, and put your implants. So that's basically now. I've said about the valve. You have to prime the valve mechanism. But for a non-valve, you have to ligate. You have to ligate clear pad, even this is what called reed cord, like a stent. 5-O proline can do that. You just put through into the tube and leave it there. It will also reduce the space. Then you ensure that you ligate that tube very well. You must ensure that after ligation, you want to ensure that no drop of fluid actually flow through it. It is very, very important. You have to ensure that. Otherwise, you may have hypotony early in the distance. And it's going, in fact, you may end up explanting that tube because the hypotony is worse than what you see in trabeculectomy. So you must ensure that you actually ligate that tube very, very well before you secure the plates. Like I mentioned, yes, 5-O proline can use a stent and everything. Correlate cord can do that. After that, after you have done the occlusion, like for a valve, usually after I've finished the securing and I have inserted the tube into the AC, actually put like 1 or 2 stents. I made a, not stent, I just made a perforation into the tube. So that will help in draining some fluid. That is anterior to the ligation. You just make 1 or 2 slits, and that will help the IUP to a bit not to be very, very high, as it will be dropping until you have your capsule from 4 to 6 weeks, and the ligation will have melted. There are some surgeons also that they do a 2-stage procedure, all in a bid to actually prevent post-operative hypotony. And in that case, what you do is that you secure the plates in place, but you will not insert the tube. So you can just place the tube under cover the conjunctiva. 4 to 6 weeks later, usually 6 weeks, you now come back, open the conjunctiva, you now insert the tube into the AC. At that point in time, you believe that you don't need to do it because you're not going to ligate. You believe that the plate will have formed, which will now serve as a pressure modulating mechanism to actually regulate the flow. So by within that 6 weeks, the capsule will have formed. So you can now come in and you put the tube and you close the conjunctiva. So that's some surgeons that do that. I've never done that. I just do once, and I've never had issue for the ones I've done. So once the blood is in position, the plate is secured. The globe, suction, okay, I've been that. After that, now if you look at it, when you are putting the tube, you can see that picture there. You probably want to see the tube at least 2 to 3 millimeters from into the anterior chamber. Ensure that, well, the tube is not too long to reach the pupillary axis, also not too short, because you will have a retraction. Somehow, there may be some level of retraction. So if the tube is very close to the trabecular area, the angle area, is likely going to retract into the subconjunctival space. At that point, you see that the opening will close, and you may have to come back to either use a tube extender to extend that tube, or you probably, if you don't have a tube extender, you may probably have to expand the entire tube and put another one. So that's basically, so once you have done everything, you secured the plate and you now measure. Now, in order to, when you want to put the tube into it, when you're cutting it, you must cut it bevel up so that the tube, you can see this, the tube here. It's a bubble envelope, so the aqueous flows through it. If it's bevel down, it's going to affect the flow of aqueous. That's number one. Ensure that the tube is not close to the cornea, neither is it close to the iris. It's just in between. And so when you are going to insert the tube, what we use 23G. I use 23G. I think I generally use 23G needle, maybe about 1 millimeter from the limbus. You actually use that to create a tunnel into the anterior chamber. You must ensure that this is parallel to the iris so that it doesn't go deep and touch the iris. So you just use that. You can shake the needle a bit inside the sclera to give a bit of space. From through that place, you can put the tube. Then you use a suture, a non-adhesive suture to secure it at that limbal area, to secure the tube there. Obviously, you will have secured the tube also in the sclera. Now, let me say this. My trainer will always say, and I actually agree, that you have to leave some level of tube, a kind of redundant part of the tube on the sclera. Peradventure, something happens tomorrow, maybe you have a retraction, whatever, you can easily you open your conjunctiva, you have a redundant tube, so you just put it back. But if you cut the tube in such a way that you don't have it and anything happens, it means that you have to now use a tube extender. And tube extender is actually a bit difficult this thing to do. So what I do is that I actually leave a redundant part of the tube, which you will see in this. You see this image here. That's what. So I leave a kind of curve that's on the sclera, as secure to the sclera, so that if anything happens, I can easily come back and use, and I still have some tube to actually use into the AC. After you have done that, well, initially I used to have a scleral patch to cover the tube from my trainer, but as time goes on, I don't have that. So what I do a tunneling. I just tunnel the tube. You can tunnel the tube into the sclera, maybe like maybe between 5 to 5 millimeter or so from the limbus. You can tunnel it down into the, so that's covered. Or you can create a kind of flap, like as if you are doing a trabeculectomy, and use it to cover the tube. Because you don't want, when a patient, somebody is seeing a tube somewhere on the patient's eye. So for those who have scleral patch, cornea, donor cornea, they can use that. Some they use pericardium, but I think that would be a luxury for us in this part of the world. But if you don't want to put the tube in the AC, because the AC, you feel the AC is not adequate, you can put it in the sulcus, but that must be in a pseudophakic eye. Or you can also put it in the vitreous, anterior vitreous, for an eye that has had past planar vitrectomy. You can do that. I think I've seen that, my trainer have done that, I've seen that. So you can do that and it will drain. It will drain. But like I said, if there is no vitreous, like a phakic glaucoma, you can also put that in a phakic glaucoma, but you must clear that anterior vitreous, because once the vitreous enter that, you're going to block and you are going to have pressure rising up again. So that's basically, after that, you cover and you can give your subconjunctiva antibiotics mixed with steroid, cover the eye, close the conjunctiva. Like I said, it's not as precious as when you are doing trabeculectomy. We want to cover the conjunctiva, meticulous, don't want any leakage. No, this one, you don't do that. Just cover it and it's okay. At the end, like I say, put your injection, give and dandruff, and cover the eye. Now, the use of antimetabolites has been the results have been conflicting. And so it is not a routine to actually use antimetabolites to do that. But you can, if you want to use, you can use, but it's not like trabeculectomy, where if you don't use antimetabolites, you already prepare for a failure. But for this, you don't necessarily have to do it because the results have been quite conflicting. You can see that I don't want to go in that. Now let's go to the post-operative care. On first day, post-op attention should be on the tube position and in wound architecture. Topical steroids are commenced. For valve, all glaucoma medications are stopped. Take note. For valve, all anti-glaucoma medications are stopped to prevent hypotension. Whereas if you are valve, for non-valve, you need to continue your anti-glaucoma medication until around 4 to 6 weeks. So that's why I said for non-valve, patient follow-up is a bit tighter compared to the non-valve. So that's basically what you have to note. Now, when things will be going well, and you need to inform the patient for a valve, or generally you have to, for a valve, yes, you need to let the patient know. That will be an initial hypotensive phase. I remember when I was training, our patient that, when I saw the result, the first day 8, and fantastic, everything. But after about 2 to 3 weeks, I noticed that the pressure started going up. So I was now asking my trainer, what happened? So I went and now realized, yes, for non-valve, for a valve, you may have this hypotensive phase and everything. But after like 3 to 4 weeks, pressure started going up. Because at that point in time, you now have the fibrous capsule being formed. Remember, you already have a valve mechanism. Now, the fibrous capsule also form another valve, another kind of restrictive mechanism. So that will now make pressure to be going up. So between around 4, 6, about 10 weeks or so, the pressure may be a bit, so you may have to like reintroduce your topical medication. But remember that what will happen now, you now begin to have remodeling of that fibrous. So by 10, 12, 13 weeks, you see that the pressure will now start dropping again because there's a remodeling of the fibrous capsule that will make the space a bit open and free for the fluid to do that. But for the non-valve, you don't really have that because ab initio from the beginning, the pressure is not going to be down. So you just watch. It's around that 4 to 6 weeks. Now the pressure start dropping down. So you need to let the patient know because the patient will say, "Oh, my problem has been solved." And doctor, what happened? Why is my pressure going up again? You need to let the patient know about that. The stable phase, I said, after that, remodeling of this thing will take care of that. Now, let's look at the complication of GDD. You may have bleeding, conjunctival buttonhole. This is like I said, but it's not really going to cause a lot of issue. But you have to be careful with scleral perforation because when you are trying to secure the plate, don't go too deep. You just take a little, but maybe about 50% of the bites, don't go too deep. Just can have a perforation while you're doing the surgery. So be careful. Make sure that the tube is not too posterior. It can be, if you notice that place, but if you already have a redundant tube, you can easily correct that right there. But if you have cut, because the recent surgery I didn't know what happened. I just cut and I discovered I didn't have a redundant distance. And by the time I put into the AC, I noticed that I couldn't really see my tube very well. But well, it's just flushing around that angle area, which is not good because over time there could be a retraction and that may be a challenge for the patient. You may have a tube misdirection in the tube length and the flat anterior chamber, suprachoroidal hemorrhage. So those are the things you have intraoperatively. Post-operative complication, hypotony for a valve is not really common. For non-valve, if there is a significant wound leak, that could be hypotony. Some valve too can have hypotony, but usually it's short-lived. And for a valve, you don't really worry. You can actually adjust your steroids to increase wound healing, so that you can ensure that if there is AC shallowing, you put a visco. From my experience, hypotony, is not like what you get in trabeculectomy. But if you made a mistake for not ligating a non-valve, you are going to have worse hypotony than what you experience in trabeculectomy. So take note, I want to reemphasize again, ensure that for a non-valve, ligation is total and absolute. Otherwise, just go back, remove the tube, and save that eye. We have a valve malposition. That's why I said you have to be careful when you are priming this thing. Otherwise, it turns a valve to a non-valve. We have a femur, just like you see in this image. We have perforation. Yes, corneal decompensation can occur if the tube is. Ensure that before you close, look at your tube very well. Ensure that the tube is not going very close to the endothelium, the corneal endothelium. Please ensure that. Otherwise, you have to remove it and do another tracking to the AC to avoid that this. Because after some time, you just discover that the cornea is becoming easy. Overhanging bleb can occur maybe because of too thick scleral patch, and you are very close. The plate is slightly anterior, so you may have that. You have tube erosion. The tube, that's why you need to cover it. You need to cover it. Otherwise, you can see the tube can erode and expose, can even come out. You'll be seeing it on the conjunctiva. You just see that on the conjunctiva. It may have endophthalmitis like any other surgery. That's this is an assisted bleb. If you have something like this, you can see this is the tube somewhere here. This is the tube here going to the anterior chamber. Then this elevation here is the assisted bleb. Well, in this case, what you do, you can actually aspirate. You can also, after you can also give antimetabolites. It might probably help in the modeling. After some time, it will resolve. But if because once you remove it, after some time it enters, you just keep doing that. I remember one particular patient. We do that like a couple of times, and it works. But one recent patient I did, I think it happened like I just aspirated it like twice, and it resolved. I increased the steroid medication, and that helped, and it resolved. Other tube-related problem would be the tube will block, retracted. The tube can block from blood clot, fibrin, vitreous, iris incarceration. That's why you don't allow the tube to lie on the iris. Let it be in between the iris and the tubule. Those are the mechanisms you can use to dissolve clots, but it's not accessible to us. For those who are accessible, we can do that. If the tube is blocked by a vitreous, we have to do a vitrectomy. Refer the patient to a vitreoretinal surgeon to do that. You have migration expansion of the plates. Yes, I have this recently. I don't know what happened. I think either the conjunctiva became a bit necrotic and exposed the plates. I said, okay, initially I didn't want to remove it. I told my resident, okay, let's go. Let me do a graft. Let me do a conjunctival graft. My resident told me that I feel like this thing will not take. I said, don't worry. I did the graft and covered the plates. Not up to 2 weeks, the graft failed. So I just have to explant the tube. So you have to be very careful that. Then you have motility disorders, zootropia. That's why you have to be, for those wide surface plates, ensure that you do not put it on the muscles. Be sure that it's actually under the muzzle. Even at that, some over time, maybe because of, you may have a bit of restrictive movement, but may not be as severe as when you actually place it on the muscles. Elevated IUP, early IUP, we'll talk about that. Late elevation IUP is usually due to thick fibrous capsule, and this can be dealt by removing portion of the capsule beneath the conjunctiva. That can be done. Now, let's look at comparing the various drainage devices. There are two major studies that have actually compared BEVEV and Amid valve FP7. I think the results is actually comparable after 5 years. In the ABC study, the mean IUP for BEVAV was 12, and for AMED, about 14. The complications, I think, relatively the same. Hypotony tend to be higher in this. And you also have the AMED versus BEVAV this study also. Now that study is that persistent hypotony, explantation, and loss of pelvic was more in the BEVAV group compared to the AMED group. Now, looking at recent plates like RD compared with maybe BEVAV, well, we don't really have a randomized trial, but there are a few prospective studies, few retrospective studies that show that they have comparative results and complication profile. So that basically what you do that. So depending on which tube, all the tubes are okay. If you have access to any of them, I think you should be able to use them. Now, let's compare implants to trabeculectomy. No doubt about that. The primary, the tube versus trabeculectomy study and the primary tube have actually shown that these conditions are comparable. Let's look at the TVT study said both procedures were actually with similar IOP reduction and use of supplemental medical therapy at 5 years. Additional glaucoma surgery was needed more frequently after trabeculectomy with MMC than with tube. That's the TVT. And remember, for TVT, the surgery are done in eyes that have had failed trabeculectomy or the phakic or that have had other previous surgery before, a cataract or trabeculectomy. This is essentially what, now for the primary tube versus this, at 5 years follow-up, the mean IOP was similar in both groups. Now, these two studies actually giving the evidence that you can use tube not just as a secondary procedure, you can actually use as a primary procedure in a patient with even the primary open angle glaucoma. That's primary open angle glaucoma. You can use that. I've done a couple of them, and they are good. The most important thing is that you must do your patient selection very, very well so that you don't run into problem. I was saying there's a recent systematic review looking at BEVAV, AMED, Express, and Zen. If you look at this, and you find that incidentally that AMED after appears to do better than the BEVAV. Well, I know that the study have a bit of some drawbacks because some of the studies that were included in that review were not randomized. So there could be some biases and those stuff. But, we believe that the non-valve actually have, because if you look at the non-valve may have a better IOP control in the long run compared with the valve. Even from my own experience clinically, I say that you have the low things more in the non-valve than in the valve. But this review is trying to say something else. So we begin to look at things differently. But before I conclude, looking at the comparing trabeculectomy maybe in all those refractory glaucoma, which we mentioned as the indication for the valve, there's recent reviews, the review that show that the outcome are actually similar. So we normally say, oh, if you have universal glaucoma, if you do trabeculectomy, it's going to fail and everything. But a recent review has shown that they actually have comparable outcome, trabeculectomy and the tube. So let us not abandon our trabeculectomy. Maybe you have a universal glaucoma and you say, oh, you don't know what to do. You don't have access to tube. Do your trabeculectomy. You may save that eye. That is essentially what I want to say. I want to conclude by saying that glaucoma devices are no longer reserved for refractive glaucoma. They can be used for primary glaucoma. They are effective, they appear to be effective than trabeculectomy and less postoperative complication. Commercially available devices have comparable efficacy. However, the major problem we have for us is access to these devices. They're expensive, and so we are not doing the surgery as much as supposed to do. Anyways, I think we begin to look at seeing how we can put pressure on the industry, those manufacturers, to see how they can bring down the prices for us in Africa, so that a lot of our patients that actually need this surgery can have, and we can, retain their vision, control their IOP, and give them good quality of life. Thank you very much.
Thank you so much, sir. It's been an interesting session with you, Dr. Godswill I Nathaniel. I know we can all attest to that. Thank you, sir, for the detailed webinar on GDD. You mentioned some of the classifications based on the plates, the material, the type of opening, some indications like refractory glaucoma and also primary glaucoma, which you mentioned. Then some of the contraindications like extensive conjunctival fibrosis, scleral thinning, some important preoperative considerations, proper patient selection, ocular examination to rule out some risk factors. The selection of plates to use, preferably silicone, is more preferred in an inflamed eye. And also the choice of anesthesia. Then some important surgical considerations that were mentioned. The superior temporal quadrant is more preferred when using single plates, and it gives better exposure. Now, for the limbal-based conjunctival flap, this is preferred in a small eye. The Fornis base is preferred in a large eye. Then for valve implants, it's important to prime. For non-valve, ligation is absolute. Now, it is important to ensure that the plates or the tubes are not too short or too long to avoid tube retraction or tube corneal touch. And tubes can be placed in the anterior chamber, in the sulcus, in the pseudophakic eye, in pes plana, in vitrectomized eye. Now, the important post-op care that was mentioned for valved tubes, it's important to stop all glaucoma medications with also note that there's an initial hypotensive phase. Now, for the non-valve, continue glaucoma medications till 6 weeks. There's some important some complications to note, such as bleeding intra-op, post-op. They can have hypotony, persistent bled, or plate migration. Wow, thank you so much, sir. It's been an interesting session. The only drawback to this is costs, which we know that we'll get there very soon. Thank you so much, sir. Thank you. Now I'll welcome comments, questions from participants. Thank you. Are there comments or questions for Dr. Godswill Nathaniel, please?
Yes, ma, there is in the chat box.
Okay. Okay, someone is asking if you can have the slides, sir.
Yes, why not?
Hello, sir.
Yes, we can have the slide. I'll send it. I'll send it to Idris. Idris will actually distribute it to the forum.
All right, thank you so much, sir. I think other comments. Okay, someone is asking if for those that use anti-metabolites for GDD, at what stage in the surgery can it be used, sir?
Just like trabeculectomy.
Then is it used? Okay.
You can use it. You can use it intra-op. You can also use it post-op. It's just like after you have raised your conjunctival flap. Sorry, you have done your conjunctival peritomy. After you have done your conjunctival peritomy, all right, you can apply this thing. You apply the MMC or the area you want to put inside the plate. So it must be very, very posterior. Should be quite posterior. You want to around the area. You want to actually secure the plate. That's where you apply the anti-metabolite.
Okay, so the person also went ahead to ask if it's if it is used as soaked, pledged, or injected.
Yes, you can use as soap pledged. I think that's the one that's commonly used. You can actually give it subconj. Perhaps you give it subconj maybe like about 30 minutes before surgery. You can do that 30 minutes before surgery. You just give it a bit more posteriorly where you know that your plate is going to be towards that side. You give it subconj, and 30 minutes after, you can now start your surgery.
Okay, sir. So another question. Someone is asking if a patient with severe conjunctival fibrosis, can amniotic membrane graft be used?
Well, I'm not sure because it's because by the time when you are doing that your peritomy, you discover that you cannot really drag your conjunctiva to cover at the end of the day. I'm not sure whether amniotic membrane will help. There's a possibility. There's a possibility that it will help, but I've not actually considered that. There's a possibility that it could help. But another thing is this: how accessible is amniotic membrane? Amniotic membrane now, like the dry one I used to use, is quite expensive. The dry one I used to get abroad now is quite expensive, almost $2,000. So how many patients can afford that? So adding that to the cost of the surgery, it's going to be quite challenging for the patient, yes.
Thank you so much, sir.
One
other question, yes, sir. Someone asked, would there be a need for surgical revision in a case of pediatric patients who had GDD?
Revision.
Hello, sir.
There could be revision. Depending what you say revision, what are you revising? Like now, I actually inserted Ahmed valve in a 12-year-old boy with juvenile glaucoma, and initially the pressure was controlled. Like I said, you have that. Then you now enter into the hypertensive phase. The hypertensive phase took quite a long time, and you know that in children, the rate of healing is very, very significant. So that fibrous formation was quite intense for him. So we have to restart the patient on topical medications and everything, and some because the pressure was just too high. And in that case, what I need to do is to put a second tube. You put a second tube because there's no problem with that. You can only, if you have a problem with either the plate or there's a tube retraction, there is tube exposure, you cannot do a revision. You may do a revision. And in that case, you can still use that tube and do that. But you have to be very careful. There's one particular case I and my trainer did. I think we were not the one that did that surgery. He had the surgery done somewhere in Germany, and he had the tube retracted. Now he came. We have now he had a good redundant somehow tube. So we actually opened up and push the tube a bit, release the distance. The patient eventually developed endophthalmitis. And it wasn't a funny thing. We now started battling how to handle the endophthalmitis. So when you want to do a tube revision, you have to also be very careful. Ensure that the patient's ocular hygiene is good and everything. Otherwise, it's better you explant. If you have issue with that, you'll be better explant than to go and be trying to do something and still be pushing. Now you remove the tube and put it back. You have to be very careful. You have to. But if you are not satisfied with the IOP control and you don't have any other surgical option, you put another tube. That's the best option. Put another tube. It will help. I've said that some patients do have 2 or 3 tubes just in order to control their IOP. So that is it.
Right, sir. Thank you very much, sir. I think that will be all from the chat box. Sir, we really want to appreciate you for this interesting topic. We expect to see you more on our webinars. Thank you so much. I will, at this point, want to appreciate all of us for being part of this 3rd quarterly webinar session. Thank you so much, everyone. Do have a beautiful weekend. Thank you. Thank you, sir.
You're welcome. Thank you, YOC, for the invite opportunity to share my own knowledge. Thank you.
Thank you, sir.
Yeah, thank you so much. I really appreciate it.
Mr. President of YOC?
Yeah. Yes, it's the chair, sir. Thank you.
I greet you. I greet you. I greet you
Yeah,
very much.
this
Thank
is
you.
a special webinar. We really enjoyed it.
It's okay.
All right.
Yeah, have a nice day.
Thank you, sir. Mr. Chairman, sir, any information for us?
We're looking forward to everyone at Candle OSM.
Okay.
Take time to be with us at the web session so that we have interesting activities covering WIO's presentation. We have a competition for the best WIO paper, and then we have AGM and handover this election year. So make sure you make it an event to attend.
To be there. We all look forward to be there, sir.
All right.
Thank you so much. Thank you, everyone.